Good evening. It's a pleasure to welcome you all to tonight's important and inspiring event. As mayor, I'm honored to stand before you with a room filled of individuals who care deeply about their health and the health of our community. We are privileged to have tonight a distinguished panel of health professionals from the Aventura Hospital who bring expertise, passion, and a shared commitment to wellness. As a member of the Board of Trustees for the Aventura Hospital, I am especially proud to bring this event to my fellow residents of Golden Beach. Tonight, they will be sharing valuable insights on women's health, cardiology, and general wellness, topics that impact every one of us and our loved ones. Their knowledge and their dedication helps us guide us toward healthier lives, and I am encouraging you all to listen, engage, and take full advantage of this opportunity to learn. Thank you again for being here. Before I turn it over to the moderator, I want to thank Carolyn Hunter, the Chief Operating Officer of Aventura Hospital. Thank you. And Vernicia Larce, who's really helped put this thing together and has been working with the Golden Beach team to get the word out, and it's thank you. I can't thank you guys both enough. So now I'm going to turn it over to the monitor tonight, Jennifer Garusi of HCA Healthcare, and please join us and welcome her today. Thank you. Thank you so much.
Thank you all for being here. I would like to begin tonight by first of all thanking the town of Golden Beach for graciously hosting all of us. We're so fortunate to have an outstanding panel of physicians with us tonight, leaders in their field, passionate about advancing health and wellness in their community, and how lucky are we that they all practice medicine just down the street. So please join me in welcoming them. We're going to start with some introductions. First here is Dr. Daniel Donato, board certified in gynecologic oncology. He was raised in Florida and he did all of his medical training at the University of Miami School of Medicine, Jackson. Dr. Donato has more than 35 years of experience in the surgical management of all female pelvic cancers, which include uterine, cervical, vulvar, and vaginal cancers. Dr. Donato has extensive experience in robotic surgery for women who have either complex female pelvic problems or cancer, and he sees patients at HCA Florida Institute for Gynecologic Oncology, Aventura. Next, we have Dr. Juan Velasquez, is board certified in interventional cardiology as well as cardiovascular disease. He has 15 years of experience in the prevention, diagnosis, and treatment of cardiovascular diseases such as coronary artery disease, heart failure, and valvular heart disease. Did I say that right?
Got it.
Dr. Velasquez completed his medical training in Columbia before joining Emory University School of Medicine, where he completed an internal medicine residency, clinician, scientific pathway, and interventional cardiology program. Dr. Velasquez sees patients at HCA Florida Heart Specialists.
All right, thank you so much.
Next, we have Dr. Eric Schiffman. He's board certified in orthopedic surgery and is committed to providing solutions for bone and joint conditions that improve his patients' quality of life. Dr. Schiffman began his medical studies at the Albert Einstein College of Medicine in New York City and completed his orthopedic surgery residency at the University of Miami-Jackson, where he benefited from comprehensive surgical experience and developed expertise in complex orthopedic trauma procedures. As chief resident, Dr. Schiffman took an interest in joint reconstruction and pursued his subspecialty in an adult joint reconstruction fellowship at Massachusetts General Hospital, Harvard University. He was later appointed head of the joint reconstruction program at Adena Regional Medical Center outside of Columbus, Ohio. Dr. Schiffman is part of HCA Florida Healthcare family and sees patients at HCA Florida Aventura Orthopedics. And Dr. Christina Tongson is board certified in breast surgery and is the forefront of bringing single-dose intraoperative radiation therapy, working closely with her radiation oncology and medical oncology partners to deliver radiation at the time of surgery. In addition to treating patients with benign and malignant breast disease, she has a special interest in caring for patients at high risk for developing breast cancer. Dr. Tongson earned her medical degree from Kansas City University of Medicine and Biosciences in Kansas City, Missouri, and completed an internship and residency at Larkin Community Hospital in South Miami. Dr. Tongson sees patients at HCA Florida Miami-Dade Surgical Specialists. And last but certainly not least, Dr. Gerardo Kahani is board certified in general surgery and specializes in minimally invasive procedures for hernia repair, gallbladder and abdominal surgeries, and bowel obstruction. Dr. Kahani is originally from Mendoza, Argentina, and completed his medical studies at the National University of Cuyo School of Medicine and went on to Conemaugh Memorial Medical Center in Johnstown, Pennsylvania for an internship and residency, then Brooklyn Hospital Center for a residency and fellowship at the University of Miami. Dr. Kahani sees patients at HCA Florida Miami-Dade Surgical Specialists. So tonight we have a unique opportunity to explore healthcare really from multiple perspectives, from prevention to complex treatments. We're going to talk about heart health, cancer care, surgical innovations, and how we as a community can better support patients through every stage of their journey. And then at the end, we'll open it up and take some questions from the audience. So let's start with Dr. Velasquez. Heart disease remains the leading cause of death, but what are some of the most important things people should know today about prevention and early detection?
Sure. I think there's a lot of things that could be achieved with lifestyle. And it seems like lifestyle medicine has become a field, and a lot of people are talking about it. I would say there's two very common questions, what to eat and what to do in terms of exercise. So as far as, diet and cardiovascular disease, this is something that's being looked at extensively. They've done studies on, the Atkins diet, the South Beach diet, keto, you name it. But really, the only diet that has been shown to have a significant improvement in morbidity and mortality from the cardiovascular standpoint is the Mediterranean dietary pattern. So leaning towards a Mediterranean dietary pattern is definitely something that would have a significant impact on cardiovascular health. And then when it comes to exercise, the official recommendation from the American Heart Association is to perform, at least 150 minutes of aerobic exercise of moderate intensity. So it could be, 3 50-minute sessions or 5 30-minute sessions. But if you ask me which of the two would be better, more sessions but shorter would be better. So definitely diet and exercise. And when it comes to diet, again, the Mediterranean dietary pattern is the way to go.
Wonderful, thank you. And speaking of prevention, cancer screenings and prevention are just as critical. Dr. Tongson, what are the latest recommendations for breast cancer screenings, and how has early detection changed?
So this has been a controversial conversation in the past 10 years because the guidelines have changed. I'm sure everyone has been a little confused lately, but it was always age 40, start your annual mammography. Up until about 7 to 10 years ago, U.S. Preventative Task Force raised the age to 50. A few years after that, they decided we need to bring it back down, but that's because we were getting a spike in number of later stage at time of diagnosis. So they knew that we needed to bring it back down to 40. So where we want to start at for an average woman is age 40 for your mammograms annually, and add either MRI or ultrasounds for density. And then on top of that, decide with your provider if you need to see a breast specialist based on family history of breast or any other cancers to see if you need further screenings.
Dr. Donato, similarly, what should women be aware of regarding gynecologic cancers, and how do we improve awareness around those?
As far as screening is concerned, the most significant cancer that we're able to screen for at this point, which is still one of the best screening tests of all, is the Pap smear. We start screening patients around the age of 21 and then follow them thereafter, intermittently, depending on their risk. Things that women can do to help reduce the risk for diseases like cervical cancer is not smoke, healthy lifestyle, just like Dr. Velasquez had talked about. But right now, as far as cervical cancer, smoking is one of the most important risk factors. So we tell you if you can stop smoking, you can greatly reduce your risk for developing cervical cancer. Cervical cancer also is mediated by the virus human papillomavirus, which is a very common sexually transmitted virus. And it's a prerequisite for everybody who develops cervical cancer is that they actually have to get this virus. It has to remain latent for a period of time before people develop cervical cancer. So prevention of the disease with non-smoking and, trying to be as careful as you can with protecting yourself, having your pap smears done on a regular basis are the most important things from a screening standpoint in cervical cancer. As far as uterine cancer is concerned, we usually tell people to watch for symptoms. The most important symptom to watch for is postmenopausal bleeding. So any type of bleeding that occurs in the menopause is considered abnormal. And we tell patients don't ignore it. Don't say it's because of this or that. If you have the bleeding, go and get seen by someone so you can have appropriate screening done. Something as simple as a pelvic exam and a pelvic ultrasound can help make an early diagnosis of something like uterine cancer, which could be life-saving, because early endometrial cancer or uterine cancers are all curable. Ovarian cancer is the most common, most difficult, I should say, player that we deal with, because ovarian cancer unfortunately presents with very non-specific type of symptoms. So we tell patients when you have symptoms, abdominal symptoms that are not going away after a couple of weeks, such as urinary frequency, bloating, distension, nausea, things like that. If they're not going away, even though they're very common for other type of benign causes, please go see your doc, have them at least do an exam and probably an ultrasound to help see if they can pick up earlier stage ovarian cancer, which is curable in 90% of patients. As these tumors progress, then they become much more challenging to treat.
So really pay attention to your body.
Yes, yes.
Dr. Kahane, when it comes to surgical interventions, from emergency procedures to planned surgeries, what advances are you seeing that are making a real difference for patients today?
Well, as a surgeon, we don't like emergencies. But the most important thing is try to plan. When you plan, it's always going to be better. Do the same surgery at 3 o'clock in the morning for exactly the same disease that do it as an elective procedure in any given day is much better, because we can plan, we can take care of what's going on, and then at the same time we can just be more effective. Now the advances that I can see is the technology that we have most in our hospital, that we have the state-of-the-art CT scanners, MRIs. In my personal practice, I use a lot of the Da Vinci robots to do cases. And right now, the amount of specific stuff that we can do with the robot is, compared with years ago, is completely different. I can attack small spaces and then do much more, I would say, specific movement with my hands outside of the body with the robot inside of the abdomen. So I think, and we have all that technology. So I think it's something that we are really proud of what do we have, and then how do we take care of diseases in the hospital.
Thank you. Well, we know the people of Golden Beach love to stay active, because we were just admiring the beautiful pickleball courts and the new tennis facilities out back. So the next question is for Dr. Schiffman. How is orthopedic care evolving to help people stay active and healthy longer?
Right. So I'm actually going to rewind a little bit. And for me, prevention is really much more important than any technical advances. So most important thing is weight. The thing that we see, arthritis is definitely associated with obesity. So the bigger you are, the higher chance of arthritis. So prevention is weight loss, low impact exercise. There's definitely been some advances technologically. Robotic systems, we do use robotic for knee and hip replacements, but really prevention, going back many, many years, to me is the most important, I wouldn't even say advanced, but most important factor in keeping people young and active.
Just staying healthy and
Staying
active
healthy.
and eating right?
Absolutely.
Right, Dr. Velasquez? So how do your specialties work together when a patient maybe has multiple health challenges at once? Who wants to take that one? Go ahead, Dr. Donato.
As a surgeon, we always have to rely on our internists and our cardiologists to evaluate patients that would be candidates for surgery, because some patients have such significant cardiovascular disease that it's challenging deciding whether they actually would be candidates to have a cancer-saving type of surgical procedure. So we're always relying on our cardiologists to evaluate the patients to make sure that their heart and lungs are good enough for them to undergo the anesthesia and the surgery. And I work together basically with all my other colleagues up here in one fashion or another. We have patients, unfortunately, if they have spread from their cancers to the bones, we're having them see our orthopedic surgeons to see if there's anything that they have to offer them from a surgical standpoint. I work together with Chris for patients that have diseases that go along together. For example, there's a specific gene mutation called the BRC genes. You've probably heard of them. They're the genes that are associated with both an increased risk of breast and ovarian cancer. So we share common patients that potentially, if they have that gene, can develop either breast and or ovarian cancer. From my standpoint, we'd be talking about trying to remove their ovaries at an earlier stage before the cancer develops so that they never have to go through the pain of having to deal with ovarian cancer. So we work together closely on those type of patients with genetic abnormalities that would increase risk for both of these cancers. And Dr. Kahani, we use him all the time when we get into trouble in surgery, when we have difficult patients that have bowel involvement by our ovarian cancers or our uterine cancers. So these people are, priceless companions that we work with all the time to help, give our patients the best care possible.
The other thing I'll just add in, the communication, what Dr. Donato said, I mean, it's all about communication. So whatever specialty, whether it's surgical, whether it's medical, just communicating. So I think that's the biggest, most important factor that we have with each other. And also with the patients, communication, we hear a lot of complaints that, they go to see their doctor and their doctor doesn't listen. And that should be quite the opposite. For 99% of the time, the patient is telling you the problem and they're telling you the diagnosis, and even if they don't know it. So it is all about communication. And I urge, everyone out here, make sure that whoever you're going to is really listening. Don't let them tell you, you got to tell them. And if you're not having that, find someone else.
It goes along the lines with the prevention that you asked me about earlier. Prevention with breast cancer is very tricky. A lot of our risk factors we can't control. Already with being female gender, we're at 12% lifetime risk of getting breast cancer. We can't control our family history. But if we know to look for a gene, the BRCA gene that Dr. Donato mentioned, if we know to look for something, and then let's say we have it, right? It's scary, but at least we know to be looking in advance, and we can catch things when they're more efficiently treated.
I was going to say, too, this kind of goes off what Dr. Schiffman was saying. What advice would you give patients to be better advocates for themselves during their healthcare journey?
Well, for my field, it's a big, it's a big thing right now, women advocating for their health. Typically, in the recent past years, we're kind of pushed aside when we have a complaint because we like to complain. So if you feel something new, tell your doctor you want imaging. There's a lot of things that are brushed aside, even in this field now, because there are some benign masses that, it could feel like a benign mass. But if it's new to you, make sure your doctor's checking it out. It goes along with what you were saying, Dr. Schiffman, is make sure your doctor's listening.
Yeah, one of the things that I always talk with my patient is I love to be a small surgeon. What that means, I prefer to fix a hernia like this than a hernia like that. Just look to the other way is not going to make the disease away. It's going to just give it time and time and time and everything. So take care of any problem when you see the problem, and then don't wait for something is going to happen and it's going to disappear. It's like it's always easy to go small than to go big.
So in my world, I would say that the best way for a patient to be an advocate for their health is to try to avoid going by the traditional paradigm that a cardiologist needs to be looked for when you have established cardiovascular disease, because preventive cardiology is a field. So, in my mind, any male over the age of 45 or any female over the age of 55, even if they're asymptomatic, should see a cardiologist for preventive cardiology reasons. Because cardiovascular risk factors are very common: hypertension, high cholesterol, diabetes, all these issues, associated with obesity and metabolic syndrome, insulin resistance. So definitely going against the paradigm that cardiologists need to be looked for only when when there's established cardiovascular disease.
Very good.
I'd say, ladies, please don't let the physicians that you see ignore your symptoms. I see so many patients that have gone to other doctors for bleeding, and the doctor says, don't worry about it. It's nothing. It's just menopause. Don't think about it. Or I'm having bloating. I'm having symptoms that could be ovarian cancer. They don't even get a physical exam of their abdomen. So if you're feeling something and you're concerned about it and you're not getting the satisfaction from your doctor, please seek other physicians that will do the appropriate things. Because again, if we pick up these cancers in early stages, you have a good chance of being cured, as opposed to just treating you and treating you and treating you, and it becomes a chronic disease state that we never cure. So don't ignore your symptoms, and don't let your physician ignore them or downplay them. And that's one of the problems I see on a fairly frequent basis.
And I would think for Dr. Schiffman, right, it's probably hard for your patients. Pain is what would bring them to you, right? So it's probably hard for them to ignore it. So should they come see you right when they start feeling something, or do a lot of your patients wait until it gets to be pretty serious?
I mean, I get the whole spectrum. I'll get people that, you know, it took them a couple weeks to get in. They no longer have pain, but those are my visits that actually take me the longest, because we really talk about, well, how can we prevent this from happening? You know, some of the patients that come in with pain, you know, that's pretty straightforward. They want an injection, they want to leave. But the ones that are coming in not in pain, they really want information. And I'd much rather spend time talking about prevention than talking about treatment. So, you know, I get that whole spectrum of some patients just want a quick fix, but a lot of people that do come in, if they're not in pain, they really want education, information, and talk about prevention. So it is the gamut that we see. But as far as, you know, should patients come in earlier? It just depends on what they're complaining of, you know, what their issue is. So it's hard to say. It just depends on what their complaint of pain is.
I think this would be a good time to open it up for questions. Does anybody in the audience have anything they'd like to ask one of the physicians?
Hi, thank you. I'm just curious about your collective opinion about people seeking on their own imaging studies to rule out occult lesions or problems, even when they don't have symptoms. I know there's a lot of debate about that, about incidental findings, but just curious, what are your current opinions? A lot of people are pursuing that on their own, bypassing their doctors, going to radiology facilities, paying out of pocket because insurance won't cover it anyway without a diagnosis. What's your opinion?
I'd say from my standpoint, you always have to weigh the benefits of the test with the risk that you take that the test is wrong, because wrong tests that are falsely positive, showing that you have something that turns out to be nothing, causes anxiety, a lot of other needless procedures to be done that turn out to be not necessary. So it's difficult to say, go ahead and get the test if you think it's a good idea, because again, the testing always has false positives and false negatives. So it's usually better to get a better idea. We have a goal in mind. We're looking for something specific based on credible symptoms or signs that would suggest that this would be the most appropriate test. So overall, I would say for my patients, I wouldn't encourage them to go and get a PET scan, you know, to say, hey, do I have any type of cancer anywhere in my body? Because again, we get these false positive results that usually require some other testing or biopsy to do, and then you have a risk for the procedure to get that biopsy done, and then you suffer a complication from the biopsy, and it turns out you didn't need to have the biopsy. So that's the kind of thing you could see how you could get channeled down line to have more risks and more problems by doing this indiscriminate type of testing. That would be my take.
Yeah, in the cardiovascular world, I would say that there's a lot of excitement with getting calcium scores, and it is definitely a very valuable test in certain circumstances, but it's definitely not the decision to get this diagnostic study is not a decision that should be made empirically by a patient. I encourage patients to see a cardiologist and then let the cardiologist determine if there's any indication for such tests.
In my world, it's not that big. You know, what we do is pretty cut and dry. But one of the things I do tell patients, you know, everyone's getting MRIs nowadays of everything. And one of the mantras I tell patients, we don't treat MRIs, we treat people. So MRIs are great because obviously they show you a ton of information, but 3/4 of the time they're showing you stuff you're not complaining about. So, if you get an MRI of anyone over the age of 50, you're probably going to find something in their joint, arthritis, tears in this, that, the other thing. Is that really their pain? So it's not that I'm against it, but it's giving us a lot of information that's probably or may not be related to what they're actually complaining of.
I agree with that. In the breast world, well, in all of radiology, you're getting a snapshot. You're getting one picture, right? Everything's changing. You need the whole picture. You need the blood work to go along with the mammogram, with the ultra, it's going to bring about more things to order, and we'd probably just route you back to the direction that medical care would bring you. But it does highlight the fact that people do feel like they need to take, charge of their own imaging or medical care because insurance won't cover the certain way we're supposed to be, being treated. So I think it highlights a lot of issues.
I want to give you a specific example of what happened in my life, in my office, and it's gallstones. You cannot imagine the amount of people that I'm seeing just because they were doing, for completely different reason, an abdominal ultrasound, and they come to me and say, oh, I have gallstone now. Okay. I always put exactly the same example. You go to the mall, you go to Aventura Mall, you grab 20 people that are doing shopping without any symptoms, without any problem, with absolutely no issues at all, and you do an ultrasound on each one of them. 4 of them will have gallstone. What do you have to do with those? Nothing. So now, sometimes you start to put together some symptoms that were really vague, so they don't know, and now you have gallstone, and now the people start to think, and at the end they just come to say, okay, just remove my gallbladder. No, wait. I'm a surgeon, I love to operate, but sometimes you don't need it. So I think that it's true to advocate for each person and each other, just because you want to be sure that you are okay, but at the same time push for images or push for labs that are not necessary, that can open a Pandora box that sometimes you cannot close. So I would say I'm against that.
Great question.
Mm-hmm.
60 years old, walking or running?
Do you have any joint issues? Either one. So, I'll kind of do an aside to that. They've done studies on marathon runners, and they're at 0 increased risk of arthritis versus the general population. That being said, if you have arthritis, I don't recommend running. So once you've already had, a diagnosis of arthritis, I definitely recommend low impact, biking, elliptical, swimming. But just running in and of itself does not put you at risk of having arthritis. Another side to that is this shoe wear. So that's also a little controversial, especially with the big onslaught of OnClouds and Hokas. Everyone's running with these super thick shoes, which you're not running the way that nature was necessarily designed it, because you're not really feeling, if you're running improperly, there is a movement back towards this barefoot style, very thin, so that way you're kind of feeling how you're running, and if you're not running well, you'll start developing some pains and probably change the way you're doing things. It's thought that the newer trend is this minimalistic type of running might actually be more protective of your joints as well. Correct.
What's your opinion on stem research, stem cell?
In the joint replacement world, it's not there yet. I think we're many years away. So stem cells have the ability to become anything, but they need, at least in a joint, they need 2 things. They need a scaffold, they need something to grow on, and they need a signal what to become. What people are doing now is charging $5,000, $6,000, $7,000. They're injecting these stem cells, which are either from your own fat, bone marrow, or from embryos, placenta. But there's just no logical sense that they can actually form cartilage floating around in a joint. They don't have a signal. They don't have a place to land. It does help potentially with some pain because of some anti-inflammatory effect, but they're not regrowing anything in a joint. In other areas, perhaps, it's more advanced, but in the orthopedic world, we're still years away from having a useful stem cell that fixes arthritis.
In the cardiovascular world, there's no benefit. It's been looked at in patients with heart failure, It's been looked at in patients after a heart attack, and there's definitely no significant benefit.
I see all these ads for hormone therapy for men and women. What's your stance on that?
So, commercials, okay. So for hormone therapy replacement, that's for postmenopausal women, you know, that has been shown to give a slight increase risk for breast cancer. We know that because of the unopposed estrogen. Our lifetime risk is affected by unopposed estrogen. Every menstrual cycle of every period of a woman's life is what gives us the risk towards breast cancer. So there is a slight risk with hormone replacement therapy for a postmenopausal female for increased risk of breast cancer. With that said, there's also quality of life. If the postmenopausal symptoms are debilitating and, you know, a topical can work, then it might be worth it, right? So it's a balance.
Yeah, from my perspective, I say risk versus benefits, just like any other medicine from aspirin all the way down the pike. The risk for hormone replacement, not only with breast cancer, but also for uterine cancer as well. So unopposed estrogen is the leading cause of uterine cancer in women of the menopause. So if we giving hormone replacement therapy to postmenopausal women, we're always giving them both estrogen and progesterone to counteract its effect on the uterine lining. So that's something, but again, these discussions always revolve around the two things, risk versus benefits. And in some women who are having a lot of symptoms and the risks are low, it would be reasonable, short-term, low dose. For women otherwise who have increasing risk for things like cancer or cardiovascular disease, obviously you have to balance the two.
Any other questions? Yes.
I don't know how to frame this, but my brother's going for open heart surgery, and my husband's numbers are, his father also had it, and he's pressing me to get an angio CT, and I got a calcium test. And I don't know, is the angio the best test to determine if you need?
So your situation is, so your husband.
No, my brother, my husband has the same bad numbers and everything.
Yeah.
So it runs in the family. And
Yeah. So regarding family history of heart disease, when does it count as a risk factor? So for family history to count as a risk factor for you, it would have to be in a first degree relative, and it would have to be premature. Premature being at an age less than 45 in a male and less than 55 in a female. I'm not sure what your brother's age is, but
no, he's 59.
so that would not count as a risk factor for you. You have to be premature in a first degree relative. And then as far as getting the coronary CTA, I go back to what I was saying before. I think that there's definitely a role for coronary CTAs. There's definitely a role for calcium scores. But I would encourage you to see a cardiologist to see if that test is really indicated or not.
Okay, thank you.
What's your thought on statins for high cholesterol?
Well, I'm a big advocate for statins. I think the data supporting the use of statins in patients with particularly diabetes and established cardiovascular disease is very, very strong. I know there's concerns regarding hemoglobin A1C and glucose metabolism, but of course, it seems like, especially in diabetic patients and patients with established cardiovascular disease, that issue with glucose metabolism is not important enough, and the benefit of statins clearly outweigh the risks.
Any long-term side effects?
So there's recent data that show an association between specifically atorvastatin, which is also known as Lipitor, and some memory loss. And so that's making some of my colleagues shy away from the use of atorvastatin. And it seems to me, from what I've seen, that rosuvastatin is the go-to statin in most situations. And I very much agree with that because rosuvastatin is very well tolerated, high potency statin with very good data in terms of cardiovascular morbidity and mortality.
And that one doesn't have the memory loss?
That one doesn't, that it's not associated with memory loss. No. The other one is simvastatin, which we used to use a lot, but it's a low potency statin that causes a lot of muscle pain, so it's kind of falling out of favor.
Hi, this question's a bit off topic with medicine, but I'm a criminal lawyer and of course follow the Louis Mangione case. I have to talk about it a lot, on TV. And you know how people's feeling is about healthcare now and insurance. And I'm just wondering how you feel in your dealings with the insurance companies. Have you had more issues? Have you seen that patients are now complaining more that they're not having coverage or it's harder to get coverage? I know that I had to have an ultrasound, a breast ultrasound, because I had dense, well, now that the world knows I have dense breasts. And then they called me back again, and they said they weren't going to cover it. I already had the one, and so it was fighting with the insurance company. What is your feeling about dealing with the insurances and what's going on now? And even the world's feeling about that what he did was right, basically,
So after that happened, it didn't get worse or better. It's just we knew the problem. People were getting denied. People are getting denied. They deny them immediately a lot of the time, and we have to appeal. We also have ways we know how to automatically appeal because these things happen so much. Luckily, I haven't gotten to that point yet for cancer treatment, but yes, it's very hard with screenings because screenings are typically supposed to be covered. And I have a lot of problems with the ultrasound for dense breast tissue. And a lot of the breast centers, they work around it. They either have us order diagnostic from the get-go, so you go around the screening thing. So we have been working around these issues for a while. And I feel bad for a lot of my patients.
Anyone else?
I guess I'll just add to that. Here, at least in South Florida, Medicare, straight Medicare is great. In other parts of the country, it's not widely accepted, but here, almost everyone accepts it. So if you're looking, at the beginning of the year for plans, Medicare seems to be a better one down here. But a lot of patients that have, certain restrictive plans, sometimes, we're fighting to get an MRI. We're doing what's called peer-to-peers. They get denied, so we fight the insurance company. But then they, partially cover it. They might have a deductible copayment. So it's just really understanding your individual plan because we'll have patients, they get denied. They wind up having a high deductible. They're paying for the whole test anyway until they hit their deductible. But if they paid for that same test out of pocket, it would have been a couple $100. And now they're paying $800 for the MRI when they could have paid $300. So it's also knowing the individual plan that you have and what it covers and what it entails. So I'd encourage people to really understand, call their insurance company and see what, even if their MRI is covered, how much is it going to cost them? Because it might still be cheaper to do it out of pocket.
Going back to preventative medicine, and I'm sure a lot of the people in this room probably are at risk for, or maybe even have been diagnosed for osteopenia and osteoporosis. Again, do you have to wait until you have symptoms? Where are we with regard to preventatively diagnosing things that otherwise, if you wait too long, you're then on that treadmill?
Right. So, osteoporosis is a great example because it's one of the silent diseases. You don't feel it until you either get a fracture, you fall and you break a hip, back, wrist, or you get a bone density test. That's how you diagnose it. So for prevention, it's weight-bearing exercises, muscle building, and actually hitting the pavement. So walking or doing any kind of weight-bearing activities is prevention. But it is sometimes nice, especially if you're light-skinned, older, female, you're at higher risk of osteoporosis. So that's where screening is very important because even with exercising, muscle building, you can still be at high risk. So definitely a big advocate of screening for osteoporosis.
And is that something that's typically covered by insurance? Or
Yes, every 3 years typically.
What age do you recommend that starts the bone density screening?
Women at menopause.
At menopause?
what about guys?
65.
Do you see osteoporosis more in females, or does it not discriminate?
No, light-skinned females.
Females is more.
Osteopenia.
Yeah, if you've been diagnosed with that, what is the best thing to do so it doesn't turn into osteoporosis?
Exercise. I mean, they've done some studies about calcium and vitamin D, and when I started practicing, we would recommend everyone take calcium and vitamin D. The newer studies doesn't really affect the risk of fracturing. I mean, that's really our goal, is to prevent fracture, hip fractures namely. So we haven't noticed that vitamin D and calcium are doing that much, but exercise. And I know it's like a broken record. I keep saying exercise, exercise, but really that's what the treatment is, or the prevention is, exercise. It's actually not, you know, as people get older, it's funny, we're in this world where, you know, half my patients are struggling to lose weight and the other half are struggling to keep the weight on. But, you know, older people in general, sometimes they struggle to keep weight on, so they're getting thinner and thinner and thinner, less pressure when they walk, higher chance of having thinner bones.
Simple question. Do you believe in a daily multivitamin?
Mm-hmm. Good question.
Anyone want to?
I don't have a clear opinion on that. No, I'm taking. If that helps.
I think it depends on also your blood work, you know, if your medical provider's doing your blood work and you're low on vitamin D, then take the multivitamin because it has vitamin D in it.
In my world, I would say that it's an interesting paradox because there's a lot of basic science data showing an association between oxidative stress, oxidation, and cardiovascular disease. Despite that, there's no study that shows a benefit of like vitamin E or any of the supplements, which are antioxidants, showing a reduction in cardiovascular disease. In my mind, it's a low-risk intervention that, you know, if you have the money to do it, you buy it because there might be a benefit, but it's not really a data-driven thing. It's not scientific.
And I would say food is medicine, so if you could eat your vitamins, it's much better than taking the supplement.
Yep.
I have a question for Dr. Schiffman. For going back to osteoporosis, what do you think of, besides exercise, for those medications that build your bone back up?
Right. So if you are diagnosed in the osteoporotic range, I think they're worth it. I mean, there are, yes, everything has side effects, but, you know, the fear is a hip fracture is a life-changing event. So if you're really osteoporotic and you fall, you break a hip, I mean, that is a life-changing event. So I do recommend treatment if you're crossed that border into osteoporosis. There's different ones, but some type of treatment.
Okay. Well, Dr. Donato, Dr. Velazquez, Dr. Schiffman, Dr. Tongson, Dr. Kahani, thank you so much for the insightful discussion tonight. Thank you so much.
I can't thank you guys all enough for the presentation. The questions were great. The answers were better. And I want to thank all the Golden Beach residents and our guests who came this evening. Hopefully you learned something. Hopefully we'll all extend our lives. But I have to thank our town manager, Alex Diaz, Michael Glidden, who really helped put this on, and Lisette Perez. And please, there's tons of food and dessert. Take some home for your loved ones. Don't take the sweets, though, after this presentation. Just take the healthy stuff.
Thank you very much. Appreciate it.
But thank you for moderating. You did a great job, and really appreciate everything. Thank you so much.